It's my honor to introduce our speaker for Native American Heritage Month. Dr. Ryan Giroux is an assistant professor and general pediatrician at St. Michael's Hospital and the Inner City Health Associates in Toronto, Canada. He works primarily with urban Indigenous children and families, along with refugees and newcomers across Toronto and Scarborough. He is Métis from the Métis Nation of Alberta, and as well as a mixed settler heritage, and grew up on Treaty 6 and 8 territory in his hometown. I'm going to get this, Athabasca, Alberta. He is an Indigenous educator at the Royal College of Physicians and Surgeons of Canada, the Temerity Faculty of Medicine Postgraduate Medical Education Indigenous Health Lead, and the co-chair of the Canadian Pediatric Society's First Nation, Inuit, and Métis Health Committee. And finally, he's a board member of the Indigenous Physicians Association of Canada. And I'm really excited to have him introduce his talk, 7 Generations Reflecting Back and Looking Forward for the Health of Indigenous Children. Welcome, Dr. Giroux.
Right, good morning, everybody. Tansei. Thanks for the introduction. And I know there's lots of folks online, and really thankful for those who are also here in person, seeing some very familiar faces, people I went to residency with, people who got me my current job. So thank you very much for being here. Chris has introduced me, and I just wanted to add on to my introduction. So I'm a member of the Métis Nation of Alberta, Oktempissimiwak, Métis people. On my dad's side, on my mom's side, I have mixed settler heritage from various places in Europe. So I kind of bring all of those teachings with me from both all sides of my my heritage as I kind of move forward in the work that I do. And I was very thankful to see the land acknowledgement that was given earlier. So thank you very much for that. And I also wanted to add to that land acknowledgement. You know, I think we can focus on the Ohlone people that are of this particular land where Stanford sits. But as child health providers, we know that we take care of children from many different areas, many different tribes that are not in our immediate vicinity. So not only Ohlone people from across this area, but for Native American children from across this land. And I carry my responsibility as a Métis person in this space because I am a visitor here. This is not my traditional territory. So I'm giving thanks to the people who have stewarded this land for many years before me that allow me to come here. And I have to say, beautiful campus too. So everyone's doing a great job. And my commitment, everybody, you too, so don't litter. Anyway, my commitment today is to act with care. And when I was walking here this morning, I offered a little bit of tobacco to what I call the grandmother tree. She was a big tree on the walk here. And that was a way of me of giving thanks to the people that were here before, and hopefully to put us on a good path as we talk today. And my role is to be a respectful guest and to learn from those who are here and hopefully teach you something as well. These are my educational objectives. So talking a little bit about historical and current context of Indigenous people in North America and how that influences child health, figure out kind of where we are today, and hopefully the meat of the talk is really going to be what you folks can do as pediatricians and child health providers for Indigenous children and advocating for equity within healthcare systems. So you may be wondering why we're focusing on this topic today, and somebody gave it away earlier. So it's Native American History Month, and that's observed in November to honor the history, the legacy, and culture of Indigenous people in the United States. And from my research, it looks like it's been on since about November 1990. What I won't tell you is that that was before I was born, but here we are. I'm a young assistant professor, it seems. And your very next logical question may be, why is someone from Canada teaching me about this? And I'll bring us back to our this picture. So this shows the various different communities that exist within North America and beyond. And you don't see a border here. So Canada and the United States obviously have colonial borders, but our people have had relations with other nations for time immemorial for many, many years. And it's irrespective of the country borders. And I hope that I can do justice, recognizing the context that we have in Canada is slightly different, but we have many shared histories between us. And before we really get started, I just wanted to talk a little bit about language because I think it's incredibly important. And it's something that, again, is kind of grounds us for what we need to talk about. You'll hear me use the term Indigenous here, and that can refer to many things. And in this particular context, it can refer to a few different things. So in Canada, we have about 1.6 million Indigenous people, about 5% of our population. And we are very young, about 28% of our population is under 25 years old. And we are in kind of three main groups. So First Nation, Métis, and Inuit. First Nation is the biggest, Métis, my people, are second biggest, and Inuit is small, they're in the north. And when I refer to the term Indigenous in Canada, that's typically what I mean. In the United States, you might see a lot of different terms thrown around. I hope these look familiar to you. So Native American, Alaska Indian, Alaska Native, and the Native Hawaiian and Indigenous Pacific Islanders. So in the United States, there's about 9.7 million Indigenous people, approximately about 2.9% of your population. When we refer to Native American, that's really about Indigenous people in the United States and the Trust Territories, and is sometimes also applied to Indigenous communities in Mexico and Central and South America. But from a federal law and Indian law point of view, that's where you're getting American Indian and Alaska Native. And then the Indigenous people in Hawaii and Pacific Islanders are often excluded from that AIAN group. And most of the information I'm going to be sharing with you today really focuses on that AIAN and not on Native Hawaiians or Indigenous Pacific Islanders. So they're often excluded even further from many of the conversations. In the United States, about 60% of Native Americans live in metropolitan areas, and California, as I learned, has the highest number of Indigenous people, approximately 1.1 million people living within your state, which is about twice the amount as the next state. So I didn't know that before coming here, so you learn something new every day. But the greatest proportion of Indigenous people in the United States would be in Alaska, where about 1 in 5 people are Native American, and then the next would be kind of Oklahoma and New Mexico. So I'm happy to be speaking in California, where many Indigenous people live, work, and play. In terms of accepted terms, you can see here Indigenous. In Canada, we'd say First Nations, Métis, or Inuit. You may say Native American or AIAN. I think the best thing that you'd be able to do when you're referring to a person is talking about their specific community, whether that be Cree or Ohlone or whatever it might be. That's kind of a best practice. So taking that with us. So I have a theme, and you may have guessed it from my title. So obviously Indigenous child health is a topic that's incredibly important to me in my clinical work, my advocacy and research work. And when I was invited to this talk, I wanted to really make sure that community teachings are really brought to the forefront here as part of legitimizing our knowledge as people. And one of the teachings that came to mind is the 7 generations teaching. Has anyone heard of this in the room? One, okay, thanks, Jazine. Yes, perfect. So originally I thought it came from the Haudenosaunee people, but in speaking with some of my Haudenosaunee colleagues, they're like, no. And I'm like, oh, okay, I guess we're figuring this out again. And it's actually an Anishinaabe perspective. And I asked from a few different other communities, and they have similar teachings. So it's something that kind of has existed in many different Indigenous communities in Canada. And the 7 generations teaching has 2 parts. The first part is this idea that every decision we make impacts the next 7 generations ahead of us. And because the interconnectedness of our communities, our families, and our ancestors, it's really important for our communities to think ahead of the impact that our decisions will make for the next 7 generations to come. So we ask ourselves, will it lead to good outcomes? Will it lead to positivity, or will it be harmful? So that's like the looking ahead. There's a looking back part of this teaching as well. What have we learned from the past, from the previous 7 generations to help influence what we're going to decide for the future? That's kind of the second part of this. What guidance can we take from our elders, from our stories and our oral histories? And are we really honoring those who made decisions for us 7 generations ago? So as we go through today's lecture, I'm kind of modeling my teaching on this teaching. So blending them together, which is, as Métis people, we tend to do. So part 1 is, what can we learn from the past 7 generations? Part 2 is, where are we now with Indigenous child health in North America? And part 3, what do we hope for the next 7 generations for Indigenous children in North America? And perhaps most importantly for us, what can we do as child health providers? So looking at the 7 generations before. We can go way back to colonization, the settling of settlers in this land. There were many different, I wouldn't say policies, but sure, policies or ways of thinking that helped to remove humanity from Indigenous people that were here. So this idea of terra nullius, or Europeans believing that North America was a land belonging to nobody, even though we were here. The doctrine of discovery, which was a European legal principle that any land not inhabited by Christians was available to take by Christians. And then the idea of manifest destiny, which was an early American belief that the United States was divinely ordained to expand across North America. So in simple terms, people didn't exist here. Even if they were here, they're savages and this land is ours. And according to our religion, it's going to happen anyway. And then came legal frameworks within North America to dispossess land. So this is a picture of me at Pikangikum First Nation, which is in Ontario. It's a remote First Nation that is on the traditional territory of this people, but it's a very small subsect of where they would have been, where their people would have hunted, fished, lived. And it's part of a legal framework of dispossession called the Indian Act in Canada. The Indian Act gave the federal government in Canada control over many aspects of First Nations life. So that's land, governance, and identity, and really took away that self-determination and imposed colonial systems where they were kind of in small areas of land where the federal government could keep track of them. Métis scrip is really more towards my community. Essentially, certificates were offered for land or money, but was often exploited and really led to the widespread loss of our community's land and displacement across prairies, which is kind of like Alberta, Saskatchewan, Manitoba. And then Inuit settlement in the north. The Inuit were traditionally nomadic people, but they were then forced into settlements, again, to be tracked by the federal government. In the United States, similar legal frameworks were created. So the Indian Removal Act of 1830, forcing Indigenous nations from their homelands in the southeastern US to the lands west of the Mississippi, where there was mass death and dispossession. You may have heard of it as the Trail of Tears. And then the Indian Appropriation Act of 1851, almost 20 years later, that act created the reservation system, which is similar to Canadian reserves, and that confined Indigenous people to limited areas and opening their traditional lands to settlers to live in those spaces. We then have residential and boarding schools. I hope this is review for some of you, but if you haven't heard of them, they were created by the federal government and various churches, and they were intended to isolate and assimilate Indigenous children to Christianity by removing their culture and forcing Western values and social behaviors. I read that verbatim off this slide because this is probably the nicest way that you could summarize residential or boarding schools. These were acts of genocide where children were forcibly removed from their home without parent consent, and they were subjected to physical, sexual, and emotional abuse for years. And the two photos that you have on here are Holy Angels Indian Residential School in Fort Chipewyan, Alberta, and to the right is Stringer Hall in Inuvik, where my family members would have attended. And there were hundreds of these boarding schools throughout Canada, US, and Hawaii. You can see hundreds of examples here. And in Canada, the National Centre for Truth and Reconciliation and the Truth and Reconciliation Commission have documented over 4,000 deaths of Indigenous children in residential schools across Canada. I don't know about you, but I don't think any child should die at school. And the fact that there's over 4,000 documented deaths and there's likely an underrepresentation of the number of children who died is pretty staggering. In the United States, you recently had a investigative report where there was about 417 federal Indian boarding schools that were actually documented because there wasn't clear prior to this. And there was documented almost 1,000 AAN and Native Hawaiian child deaths in those schools. You also have 74 marked and unmarked burial sites at 65 different school sites. I also don't think you should have burial sites at schools. So I don't mean to, like, we're talking about the past, but I don't want to dredge up all of this and make us feel guilty. But I think we need to be really clear about what our families and communities have experienced in the past when we really talk about what we're seeing today. The residential school system was really prominent in the 1800s into the 1900s and started to kind of reduce in the mid 1900s. And unfortunately, that just gave way to different policies. So the example of the 60s This is in the 1960s, 60 scoop. Many Indigenous children were removed from their homes and placed in homes outside of their communities. And in Canada, that was about 20,000 Indigenous children were taken and adopted out, and 80% were placed in homes outside of their families and communities. In the US, about 1/3 of all Indigenous children were removed, and 85% were placed in homes outside their communities. In the United States, ICWA, the Indian Child Welfare Act, was created in 1978, which tried to give back that control to communities for children who were experiencing cases involving child welfare. And we have similar laws and ideas in Canada as well. But unfortunately, despite many years of ICWA and many years of similar thoughts in Canada, we're still seeing that Indigenous children are highly overrepresented in the child welfare system. So in Canada, Indigenous families make up about 8% of Canada's population, but we're significantly way more disproportionately able to, or likely to be in foster care. So you can see in some of the prairie provinces, that's approaching 70, 80, 90% of children in the child welfare system. In Ontario, where I work, Indigenous children are about 4.1% of the population under age 15, and 30%, there are 30% of children in foster care. In British Columbia, West Coast, Indigenous children are about 6 times more likely to be taken into care than a non-Indigenous child. In the US, the story is sort of similar. You can see here the disproportionality index for children in foster care, and you can see that American Indian children are quite significantly more likely to be in the foster care system. Moving further down, we also see that if we take gender into consideration here, Indigenous women are also significantly more likely to experience things like violence. So many of these stats are Canadian, but they likely transfer to the US as well. So in Canada, Indigenous women and girls are 12 times more likely to be murdered or missing. Indigenous women are sexually assaulted 3 times more often than non-Indigenous women. Most of the women and children trafficked in Canada are Indigenous. And then when we think about Two-Spirit or gender diverse Indigenous children, 3/4 have experienced theft or physical assault, and more than 1/3 have experienced sexual assault. And you can see from the Urban Indian Health Institute, there's about 500 documented cases of missing murdered Indigenous women and girls. That was just over 71 urban spaces, so it's likely more. Obviously, as pediatricians, we care about education, and I'm teaching you, so I hope you care about it. If you don't teach something, then we don't exist. So we see there's a huge amount of removal of our histories from education. Fortunately, in Canada, we're a little bit better nowadays, but I can reflect on when I was going to school that the main story was Indigenous people were here and we traded with them, and then they kind of left and they weren't really around, which is certainly not the case. We didn't talk about residential school. We didn't talk about any other significant negative things that happened. And now we're starting to see in Ontario, which is the graph on the left, a number of secondary schools in Ontario that are offering Indigenous studies courses increased. It's not required, but it is increased. In the United States, I think it's a little bit more behind. So 27 states make no mention of Native American history in the K-12 curriculum. So if you're not in the curriculum, you're probably not going to learn it unless your parents are teaching you. And then 87% of state history standards don't mention any Native American history after the year 1900. So again, it's being erased. We see a lot of environmental injustice, or we see that things like climate change are affecting our communities a lot more. So even something as basic as water access. So households in the United States for Indigenous people are 19 times more likely to lack indoor plumbing. And in Canada, as of a few days ago, there are 31 Indigenous communities who have long-term boil water advisories, some of them as long as 20 to 30 years. There's a nation called the Grassy Narrows First Nation, which has, there was a pulp and paper mill that had dumped more than 9,000 kilos of mercury into a river where the people would harvest fish. And since then, approximately 90% of the community have experienced mercury poisoning, including the neurodevelopmental consequences of fetal exposure to mercury. And I have patients in my practice who are from this nation, and trying to get any compensation for that has been incredibly difficult. As I mentioned, climate change disproportionately affects our communities. So things like wildfires, you're more likely to be close to a First Nation community, for example. And then food harvesting, when we think about coastal areas and the rising temperature of the ocean that changes significantly food sources that communities rely on. And then poverty. We see a poverty rate in Canada about 12%, and similarly in the United States, it's about 12%. It obviously depends on what you're actually looking for and how you're defining it. But for Indigenous children, we are seeing some Indigenous children, for example, in Manitoba and Saskatchewan, 2/3 of them live in poverty. And then in the United States, the AIAN populations have poverty rates of about 2 times the amount of the national rate, about 24%. And the median household income of those households is significantly lower than the entire nation. And as we kind of get closer and closer into medicine, I hope you've seen that we've taken things like very far, and we've kind of edged in closer and closer into our own wheelhouse, our own medicine. We still see significant racism in medicine and stereotypes. So in Canada, kids that were in residential schools were studied for malnutrition. They would remove certain micronutrients from their diets to see what effect that would have on the human body. And that's where a lot of the early research for pablum came from. But we don't talk about that when we talk about pablum. We just think it's a really great thing. We see forced and coerced sterilization of Indigenous women. That's happened as late as the late 2010s and early 2020s in Canada, where women were told that unless they forcibly sterilized themselves, they wouldn't be able to see their baby after a C-section, for example. And that's mass sterilization has existed in the United States as well. Joyce Echaquan, you see on here, is a woman who died in hospital in Quebec, in Canada, of pulmonary edema. So she was asking for help from the nurses, who then ignored her and told her that she was good for nothing more than sex, is what they told her. The only reason that we know all of this happened is because she Facebook Live streamed it, and people were seeing what was happening. Otherwise, she would have been another dead mother to 8. And in the middle here, Native Americans feel invisible in the US healthcare system is something that I think is pretty common, not necessarily existing within a space where they're talked about. We think about not talking about Indigenous people in education, we can see why people might feel invisible. And last, in terms of your programming for various different sections of the healthcare system, you can see there's a significantly less spent on the Indian Health Service per capita, so about 4,000, compared to Medicare, Medicaid, and the Veterans Health Administration. So breathe. All of this, really, if we're to boil it down, are these sorts of topics. So the effects of colonization and displacement, things like cultural genocide, a mistrust of social and health systems, a lack of self-determination, intergenerational trauma, ongoing racism in healthcare systems. These things are what are kind of the soil that the tree is growing in order to help us understand why we're seeing disproportionately negative health outcomes in Indigenous children in Canada and the United States. And I'm going to spend a little bit of time talking about what those are, but they're not very fun. They're kind of sad. And I rather focus on what we can do about it. I'm a very solutions-focused person. So in terms of life expectancy, this is in Canada, the life, again, we're going from far, we're gonna get close to kids, I promise. This is the likelihood that someone will make it to age 75. So for non-Indigenous people, it's about 75% of people will make it to age 75 in Canada, but we're seeing, close to 50% for First Nations Inuit people and about 64% for Métis people. This is life expectancy in the United States, and this is through the pandemic. So we can see that Native people were significantly more affected during the pandemic, and the life expectancy, even prior to the pandemic, was significantly lower, but is now even more low compared to all comers. Mortality and chronic health. This is a very busy slide that just essentially says everything is worse. And what we see on the left is for First Nations people in Canada compared to non-Indigenous people. On the right is AIAN compared to US. Essentially what we're seeing is higher rates of homicide, higher rates of suicide, accidental injuries, renal disease, liver disease, respiratory disease, stroke, heart disease, diabetes complications, and malignancies. Really the only thing that we're less in is Alzheimer's. And as we move closer to children, I promised you we would get to children. This is death rates for age 1 to 4 as an example. So we see in blue here on the left, those are AIAN adjusted for race misreporting or unadjusted. And this is from 2007 to 2009, published in 2014. But we see unintentional injuries, rates of homicide, rates of heart disease are much higher. And I think the important thing is when we think about death rates to this. When we think about, okay, if it only has to do after a child is born, they're born into poverty, whatever it may be, we see congenital anomalies, significantly higher death rates in AIAN children. So something even before the child is born, and now we're starting to see like the attributed deaths to congenital anomalies are much significantly higher in AIAN populations. And when we talk about unintentional injuries, that includes things like MVCs, pedestrian motor vehicle collisions, drowning, fire, burn injuries. And I hope that this doesn't come as a surprise, but risk factors for that include poverty, substandard housing, limited access to emergency medical services, low seatbelt use, et cetera. And getting to infant mortality, we in Canada and the US, we're not particularly great when we consider comparing to OECD rates. And if there's any neonatologists, they can probably say a little bit more about why that exists. But what I can say is, the best country for this is Japan at about 1.8 per 1,000 live births. In the US, you're about 5.4 per 1,000 for all comers. In Canada, we're about 4.2 per 1,000 for all comers. But if we look at these Indigenous specific rates in each of those countries, Canada, we're about 9.2, and in the United States, about 7.5. And I'll say for Canada, it's about 190% higher for First Nations children, and about 360% higher for those living in Inuit territories, which is in the north, which really is linked to access to birthing services. Thinking about mental health as well, AIAN adolescent females in the kind of 15 to 19 age group have a death rate about 3 times higher than non-Hispanic white counterparts. And in Canada, our suicide rates for our communities are 5 to 6 times higher in Indigenous people aged 15 to 24. And we see it, the Inuit people have some of the highest rates of suicide in the world, about 11 times higher than the population. Sorry for bringing the mood down. This is really sobering. I see a lot of faces and I don't see a lot of expression, and that's okay. I think that we do have to really grapple with the fact that we are seeing significant negative health outcomes for a specific group of people, and the reasons why we may be starting to see those things. Like, we have to grapple with that. If we're not even there to say, well, perhaps that is, maybe that's not what happened. Maybe there's something inherently wrong with Indigenous children. We're not even there yet. But I also want to flip it a little bit, and we think about Indigenous resiliency, right? So we can talk a little bit about why resiliency needs to exist. If we just removed oppression, then we wouldn't need resiliency. But the fact is that oppression exists, racism exists, and we need to be resilient as Indigenous people. So these are our community members who are taking a stand for what they need. You may recognize a few folks on here like Deb Haaland, and then in Canada we have Jody Wilson-Raybould. And I'd mentioned Grassy Narrows before. These are children who are protesting for their community. So I did want to, like I said, spend the majority of this time or a little bit more talking about what you and me can do and looking ahead for the next 7 generations. Has anyone seen a medicine wheel before? Is this something a little bit more familiar? Perfect. Okay. So a medicine wheel is one way that many Indigenous people understand many different things. So you can understand it in ceremony, you can understand it in directions, you can understand it as creation stories. And one way that we understand it is the idea of wellness. And when we think about wellness for our children, wellness for adults, wellness for Indigenous people in general, there's kind of 4 different things that we consider. We consider spiritual wellness, we consider physical wellness, emotional wellness, and mental wellness. And when we talk to our elders, they say if you're not kind of taking care of all 4 of these things, then you're not really well yet. So what might this look like if we're thinking, how do we vision what could be possible for Indigenous children in the future? So I thought about it like this. So from a spiritual point of view, our children are connected to their teachings and culture, and it keeps them healthy. From a physical point of view, and as a Western medical physician, I don't practice traditional medicine. I haven't been taught those teachings, but physical wellness is very important to me, and mental wellness. We want to see physical health outcomes for Indigenous children be in line with other children, including in chronic disease. From an emotional point of view, our children grow up proud of who they are, and can share how they feel with others. And last, from a mental point of view, we want our children and adolescents to want to be alive, and not only want to be alive, but they thrive from a mental health point of view. So the question that we ask ourselves is, what can you do? What can I do? I already know what I'm doing, but what can you do as a child health provider and as an ally? So I'm going to take this into two different parts. So first off will be kind of like your interpersonal relationships with patients and families, and then we'll think a little bit broader about greater advocacy. So one way you'd be able to do this is to talk about cultural safety and develop a culturally safe practice. So cultural safety is something we talk about a lot in Canada, maybe a little bit less in the United States. So as an overview, cultural safety is an approach to healthcare that recognizes and addresses power imbalances, systemic racism, and ongoing impacts of colonization on Indigenous people's health. And it goes beyond these ideas of cultural awareness, competence, and sensitivity. So those are the three blue things you see on the screen here. So cultural awareness, we start off there. I did an anthropology degree before going into medicine. And so I was like, yes, cultures exist. And that's essentially what cultural awareness is. You're saying that something else exists. I think most people are there. Cultural competence was the next thing that came. And it really discussed this idea that you can become competent in providing care to a specific culture. And when you think about that, that's pretty reductive. And it's me being like, oh yes, I'm able, I am competent in this. But is everyone the same in that culture? Can you reduce a culture to a set of skills and behaviors? I think that's pretty reductive and probably not. And then we moved on to cultural sensitivity, which recognizes the need to respect cultural differences but still focus on kind of that other culture. And eventually we got to cultural safety. So what that means is it goes beyond that cultural awareness or sensitivity and requires healthcare providers to reflect on your own biases and the ways institutions may perpetuate inequities. And essentially the patient or community are the ones who decide whether or not they've had a safe experience. You have to understand the social political context and historical context, and that brings in things like anti-racism, cultural humility, and trauma-informed care. That's a lot of big words and a lot of probably pretty esoteric understanding of what these things are, but we do have a position statement that was just released through the Canadian Pediatric Society that talks really about how you actually do cultural safety, because we have a lot of folks coming to us being like, I know cultural safety exists, I don't know what to actually do in my clinic, and this paper helps us to really understand that. And I'm going to give you like the general, like I'm not going to go through the whole paper, that would be a 3-hour talk, but give you a little bit of sense of what it looks like. And that QR code is live if you would like to look at it, or you can go to Canadian Pediatric Society's website. So this framework is kind of two parts. So one is a learn, self-reflect, and act framework, and it's a framework to guide your daily practice. And the second is called the Triple H approach. And if you've ever heard of the Shades framework for social histories or Heads framework, we're trying to insert it into that. And we talk about home, heritage, and healthy living. When we think about learn, self-reflect, and act, that learn piece is, I already know that racism and colonial systems shape healthcare provision, but how do they do that for the patient in front of me based on what I know about them? From a self-reflect point of view, I make a different relationship with each family and patient in my care, but how does my own culture and experiences shape this care that I'm providing to them? And then from the ACT perspective, I've learned and I've reflected on my positionality. How can I use this insight to improve how I care for the patient in front of me or patients like them? You can take the learn, self-reflect, ACT into the Triple H approach, and that's what I'm going to show you here. So when we talk about the Triple H approach, the first H is for home. So that includes the community that someone lives in, the housing they have, connectivity, including internet and healthcare services. So bringing in the Learn, Self-Reflect, and Act here. So we may learn that 60% of Native Americans in the US live in metropolitan areas. That's our learning piece. I'm teaching you. You've learned it. The self-reflect piece is, do I assume that any Indigenous child lives on a reservation and doesn't have easy access to healthcare? Perhaps this child doesn't live near a reservation, right? And we're making that assumption when we think about the patients that we've seen before, what's been taught to us in our education. From that ACT perspective is, okay, let's locate this family's address on a map and factor in their location to their treatment plan. Is there an urban Indigenous health center that may be able to support this family as they be discharged from the hospital, for example? In heritage, we talk about language and we talk about family structure. So our learn for heritage might be many communities practice family structures where the entire community is responsible for child rearing and attachment, not necessarily that core mom-dad relationship, maybe aunties, uncles, cousins that are involved in that. So when we self-reflect is, do I assume that any child that are not accompanied by family members who are not their mother and father have absent parents? And I think that's something that can come up. And you know, when we think about children that aren't accompanied by parents, we can have those automatic thoughts, but we really need to challenge them and do that self-reflective piece. So what we may act is to say, okay, let's explore with the accompanying caregiver how to involve the family or extended family in communication, especially if they're not physically present. And if we had done our work in the home section, we would know whether or not there's, for example, internet connectivity to be able to, you know, FaceTime them in or whatever it might be. And last is healthy living. So we talk about activity and we talk about food. The learning piece here is hunting, fishing, berry picking can be really important cultural activities that provide traditional food to communities. When we reflect is, you know, do I consider that the food served in the hospital may not be what children are used to eating at home? And that can contribute to diet habits that we're seeing when children are in hospital. I've never been admitted to a hospital in the US, so I don't know, is your food good? I see some, nobody's committing. Our food in Canadian hospitals is absolutely atrociously terrible. So I'm just going to go ahead and assume that, like, you know, we're not Michelin starring it at the hospitals. But you know, how we may act upon this is advocating for families to be able to bring country foods and having storage option for this food for prolonged hospital stays. That's something that we do really poorly in Canada. We're like, no, that fridge is for the nurses only. Like, no one else is allowed to use it. And the family's like, okay, I guess we'll just have this sad pancake for breakfast, right? Yeah, sad pancakes. So you know, I'm joking here to kind of lighten the mood, but this is bringing these, the Triple H approach and the Learn, Self-Reflect, and Act can actually lead to better outcomes, can actually lead to plans that you or your trainees can implement that helps to improve the idea of cultural safety or have that family understand that their heritage is being reflected. So if we move on beyond the individual, so we move to practicing allyship beyond individual relationships, I wanted to bring another teaching to you. So this is from Dr. Danielle Bain-Smith, Kate Johnblood, and Mandy Buss, who are people that I have learned from. And what some people say is they're like, okay, well, Indigenous leadership needs to be done only by Indigenous people, and I don't really have a space in that. I don't need to do anything about it because that's their community. And while I think that's really great to not try to take on something that you haven't been gifted, we recognize that we can't do this alone. So when we think about what we do as Indigenous people, we are in the cedar baskets, that's on the left. We are focused on Indigenous health and wellness, making sure that our communities are well, making sure that we're okay. But we also recognize that there's copper pot work, and copper pot work would be things like cultural safety, anti-white supremacy, anti-racism work, and that's settler work that is being guided from Indigenous people. It's a small aside. I know copper can be copper in Canada is generally thought of being as being a like a Western or a colonized thing, and I know copper is very different in the United States. So sorry to anyone whose communities maybe use copper traditionally, but just bear with me here. And then we see that there's a braid of sweetgrass in between the two. And what that symbolizes is teaching of Wokotowin. And that's a Cree understanding of the interconnectedness of everything. So us, the land, the waters, but also us as people. And we are all connected together to be able to do this work. And I want to impress upon you that it's all of our responsibilities to do this. We just may have different things that we need to focus on. I'm going to give you a few examples of what you can do in the copper pot work. I think a lot of you may be in a state of, okay, I need to go learn about a community. I need to partner with the community, but like, how the heck do I do that? Like, if I'm starting from nothing, this is a really excellent resource that you should take a look at. So, partnering with Native Nations in a good way. It's from the Native Governance Center, which is an American-based organization, and it literally says, "Are you interested in collaborating with Native Nations but don't know where to start?" So, very, very basic, and this is written in a way that's quite easy to understand. It emphasizes best practices like respecting tribal sovereignty, taking time to build genuine relationships, and avoid repeating harmful historical patterns of engagement. So that includes things like doing your homework about the nation's leadership, their policies, protocols, and data sovereignty. I would say, if I'm to impress upon you, this is probably one of the biggest downfalls that I see of people trying to collaborate, is they go into a partnership expecting to be taught everything that there is to be known. But if you're going to a job interview, you don't expect to be told about the job while you're at the job interview. You do your research beforehand, right? So you actually bring, and you can ask questions. You can say, this is my understanding, can clarify those sorts of things. So thinking about it a little bit like a job interview. Adopting things like a mindset of humility, openness, and patience, developing reciprocal relationships instead of kind of one-time transactional interactions, and understanding protocols for the community that may be able to create a positive relationship. So that's partnering with community. If we think about the clinical care that we may provide to communities, first off is, are we actually asking people if they're Indigenous? I know we do a terrible job in Canada. We collect data very poorly up there. But are we asking about tribal affiliation and ties? Are we considering it part of our intake in our EMR or QI processes? Or are we just doing like what some states do and don't even mention it, right? If we don't have the data, we don't have a way of understanding what we're doing well and what we're not doing well. Next is kind of looking to social determinants of health. The way, and Dr. Shazeen Suleiman taught me this, is to ask why, and to ask why, and to ask why, and to ask why. And then you eventually get upstream to where social determinants are influencing the downstream effects of child health. So this is being, for example, being familiar with best practices in clinical care that implicate Indigenous children. So mental health, toxic stress, AAP, policy statements. And then when you're teaching learners, for example, like, have we really gotten to the crux of why we're seeing something that we're seeing? Next would be kind of advocating for resources. So that includes navigation services. So we have that in many different hospitals in Canada, essentially Indigenous navigation support, where if there's an Indigenous patient who's admitted or going to a outpatient appointment or whatever it might be, they're able to call upon these folks to be able to help them navigate the systems of travel, navigate the systems of staying overnight, navigate the systems of being able to do ceremony while they're in hospital, so that they don't have to constantly fight that fight all the time. And that allows coordination with things like traditional services and healthcare. One thing I will say is it's very easy for us to advocate on what isn't there, and then to kind of say, okay, we're going to do a one-time Band-Aid solution, and this is going to improve something. But really, those, if we ask ourselves why something's happening, if we can advocate upstream at hospital, state, and federal levels, that helps us to prevent these things from happening to begin with. But it is much harder. And last thing that I might recommend is a compensated advisory circle. So, you have Indigenous faculty here at Stanford, including in medicine. How are we engaging them, and how are we appropriately compensating them for their time to be able to say, hey, here's what we may be able to do to improve the care for Indigenous children here. And if I'm to give you any kind of clinical care pieces, take a look at this. This position statement. It's from AAP CONACH, the Committee on Native American Child Health, caring for American Indian, Alaska Native children and adolescents. It's not too long of a read, but it really gives a good sense. It's many things similar to what I've said here, but it gives a good sense of what's going on in Indigenous child health in the United States. Moving on to medical education, obviously medical education is important to this institution. a couple of things that I would suggest. Teaching beyond a deficit model. As I said before, Indigenous children aren't inherently more unhealthy. They exist in systems that negatively affect their health, and that's why we see those health outcomes being worse than other children. If we shy away from understanding historical and current context, we don't really get the full picture. So embrace those, even though they're hard and they're sad and they may make you feel guilty. It's important that we actually tackle those and talk about them. And thinking about if you can include Indigenous child health explicitly in curricula. That's a hard sell. I know in Canada, it's a little bit of an easier sell. We're doing it a lot more. But iHeal, which is the Indigenous Health Educators Alliance, is a national collective through the AAMC. They have a number of different publications, which include developing Indigenous health curriculum in medical schools for medical students, consensus statements, and even an introduction to traditional healing in AI and AN communities. So you don't have to do this from scratch. Like there are people who are doing this. It's just you have to find your resources, and that's why I'm telling you these things. Next is mentorship and increasing access. Programs that foster interest and increase enrollment to post-secondary education and medicine are incredibly important. We don't just suddenly pop up and have an Indigenous physician. You need to think about it from, post-grad. We need to think about it from undergraduate medical education. Think about it from their college programs. Think about it from their high school. Thinking about it from elementary school. Really need to start thinking about what does that lifespan look like, and how do we get to where we need to be today. And there are programs that foster interest and increase enrollment to post-secondary education and medicine. So the IHS, Indian Health Service, has the American Indians into Medicine program, which is a 5-year grant that's offered to colleges and universities to support AIAN people to pursue medicine. And an example of what they're doing, the University of North Dakota is one of the recipients at the moment. They're doing student support advising circles, learning resource centers, financial aid advice, tutoring, summer institutes, MCAT prep, pathway programs that ease the difficulty between community college and university. And so my call to you is, perhaps as a state with the largest number of AIAN people, perhaps it's time for Stanford to consider doing something like this. And last is trainees should have access to mentors who really understand how it feels to be an Indigenous physician. And I had the pleasure of meeting some folks yesterday who are trainees, and it was really, really great to just be able to talk openly about the things that we experience that may be the same or may be different. As a research-heavy institute, I think I would be like pulled off the stage if I didn't talk something about research. I'm not a big researcher, I will say, but I do recognize its importance in creating new knowledge and improving outcomes for all children. So what we can look at is we can look at things like research and data sovereignty. That's a very important topic in Canada right now. So the National Institutes of Health have the Tribal Consultation and Indigenous Data Sovereignty guides. And there's various different policies that emphasize how to do this research well. There's the FAIR and CARE principles. So FAIR is kind of an open access understanding of research data. So findable, accessible, interoperable, and reusable. The CARE guidelines came from a global Indigenous data alliance, which really said, okay, great, like these are available, but how do we recognize it in the context of colonization, racism, et cetera? So what the CARE principles suggest is that there needs to be collective benefit, authority control, responsibility, and ethics that guide researchers to develop, kind of tangible outcomes that the community cares about, that the community continues to have control over their data, and that there's ethical reciprocal partnerships throughout the research process. Indian Health Services and Indian Health Services has a tribal institute review board process if you're completing any research within an IHS site. So that will automatically have some oversight into it, but being aware that that exists. And I think the last thing I'm going to say is, maybe one of the reasons why I didn't really delve into research is because of the research ethos here. Really, working with Indigenous communities requires a lot more time and a lot more patience. And if we think of kind of, mainstream views of productivity in research, which is, publish or perish, publications, grants, that may not be the priority of the community, and it may be the priority of a researcher. And if you try to bring those two things together, you're going to have a weird relationship, right? Reciprocal and good relations may be way more important than getting something done quickly. And in a system in a research system that values productivity as publications, grants, and getting a lot of output, it makes it very difficult for research to be able to enter into that, particularly early career researchers who are really just trying to get their name out there. Fortunately, there's a lot of research consortiums that already exist within the United States and Canada. These are some examples of that, and I'd urge you to take a look at some of these if research is your thing. And as we end off today, I wanted to leave you with two things. So one is allyship is a relationship with accountability. So you have invited me here as a new relative, and I have given you some of my knowledge, and I hope that our relationship has some accountability, and I hope that each one of you can think of at least one thing that you may be able to do a little bit differently as you leave today to contribute to the health of our people. And the last is a teaching. This is from Elder Albert Dumont, who's from Kitigan-Zibi-Nishnawbe First Nation, which is in Quebec. He's an elder of mine. He said, I have a memory of going for a walk at the boardwalk around Pink Lake in Gatineau Park with colleagues from the public school board. At one point where we came to where it was a rocky landscape with a variety of healthy trees, pine trees, balsam fir, yellow and white birch, etc. The roots don't go deep in this area because there's no topsoil, but the trees are doing so well. They're stretching out, interlocking with the roots of other trees, and that's what Canada should be. Indigenous roots interlocking with the people that came after, respectful and supportive of each other, where no one is superior to another. If we interlock our roots, no storm will ever knock us down. And I want to add in the sequoia tree of Stanford to this mix, and I hope that you can interlock your roots appropriately as we move forward. So one day say thank you, Kinenoskamatin. Some Indigenous pediatricians in the US that have mentored me, so Shaquita Bell, Jason Dean, Kenneth Shake, and then allies who've gotten me to where we are, so Shazeen Suleiman, who was a dear friend of mine. And thank you to my community and my family who has dreamed this for me before I was born, and I hope I'm honoring you. And I have a few minutes for questions, I think. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.